We will continue talking about cohort study design. Learning objectives: calculate relative risk and attributable risk, identify strengths and weaknesses of cohort study design. So, as we said earlier, we started with selecting subjects, identify the exposure, measuring the outcome, follow up the patients, and then obtaining the data for analysis. In cohort study design, we are interested in estimating the risk of occurrence of a disease. We previously explained relative risk. However, today we will discuss it in terms of cohort study design. So we have two major types of risks that we measure in cohort study design. We have relative risks and attributable risks. As you can see in the table here, we have, as we said earlier, we classify subjects based on their exposure level. So we have exposed, non-exposed. We compare the outcome, the occurrence of outcome after follow-up. We have yes, who obtained the outcome, and we have subjects who didn't have the outcome, no. As you can see here, relative risk, if you remember, assess how many times a factor exposure would increase the incidence of an individual to have the outcome of interest. So relative risk is basically the incidence risk among an exposed group divided by the incidence risk among a non-exposed group. However, attributable risk assess how many times factor exposure would increase the incidence rate of a group, not an individual. This is the main difference between the two. How it's calculated, it's the incidence risk among an exposed group minus the incidence risk among a non-exposed group. So relative risk can assess the chance of occurrence of the disease or the risk of incidence based on individual. However, the attributable risk compare the groups, so it can be accounted in preventing measures, more be used in preventing measures. We will talk now about the strengths and weaknesses of cohort study design. As we said, cohort is the best design among observational studies. Why it's a strong design? Because first, we can use it to calculate the incidence rate and relative risk. More than one disease related to a single exposure can be identified. For example, if we look at the association between vitamin D deficiency and osteoporosis. So we start with subjects who don't have osteoporosis, but they have different level of vitamin D. We follow up for 3 years and see who will have osteoporosis. Also, other complications could occur. So patients may develop diabetes, may develop soft bones, may develop other conditions that could be attributed to the exposure of interest. So more than one disease or one outcome can be measured, which is exactly different or in contrast from case control study design, that only we can use one outcome or one disease of interest. We can't have more than one outcome. Other strength is the causality, cause and effect. So because we said cohort studies are very similar in a lot of points to clinical trials, the causality is stronger. Cause and effect is considered to be achievable in cohort design. Unlike cross-sectional studies, that causality is very weak because of the lack of temporal relationship. Okay? Good when exposure is rare. We can use cohort study for rare exposures. However, we can't use case control study for rare exposure, as we said earlier. Minimize selection and information bias because we have control on the data. We have control on every information. We start and follow up patients and obtain all the information we need. So these two, in particular, the last two bias, information and selection bias, are seen more often in case control and cross-sectional studies because we don't have control in the data. How about weaknesses? Are there other weaknesses for cohort study? Yes. Loss to follow up. This is a major drawback of study design, because we start with subjects and we collect all this data, all this information, we follow up them over time. However, at the end of the study duration, a lot of the subjects are missed. What are the reasons? Some of them might die, some of them might leave the country or leave the hospital, transfer to another facility. They are maybe cured. So this could, or they are not interested to participate in the study. They refuse to participate in the study. So this is a challenging point. Also, in cohort study, in order to approve causality, as we said, it's a strong design for causality. So if we want to prove causality, we're going to require a large sample size. Ineffective for rare disease. If the disease occurrence is rare, for example, retinoblastoma, which is a rare type of cancer in the retina of the eye, you're gonna subjects have to wait a lot of time. You have to observe them for a long time until you reach the outcome of interest. So this is also not practical for rare disease. Long time to complete. It's gonna take long time to complete the study, and expensive, a lot of financial resources required, and sometimes we can face ethical issues. For example, if I'm looking for a relationship between certain exposure and outcome, and we found that there is an association between this exposure and outcome, is it ethical to continue observing the study, or we should stop the study and declare our results and prevent the occurrence of the disease in the other groups that are not exposed, or exposed but in moderation? So it can have some ethical issues also.